So welcome to this webinar on rapid implementation of remote patient monitoring. My name is Carissa Miller. I am the Program and Communication Specialist for Montgomery County Medical Society. I do have a few housekeeping items before we begin today. The first is that we will mute participants at the beginning of this call for sound quality purposes. To mute or unmute yourself over the phone, press *6. On PC, that's Alt-A, and on Mac, it's Shift-Command-A. We do welcome your questions. You can also submit them via the chat feature. Today's webinar will address how to get started with remote patient monitoring and explain why it might be critical to maintaining cash flow for your practice during the COVID-19 pandemic. Our presenters on this webinar are Dr. Mohseni and Dr. Amy Schiffman, who are the co-hosts of the Mastering Medicare podcast. Dr. Mohseni is an emergency medicine physician who has helped lead and develop multiple large telemedicine programs across the country, and he's provided revenue cycle management automation consulting, as well as served as the medical director for Accuhealth.tech, a remote patient monitoring and telehealth platform. And Dr. Schiffman is also an emergency medicine physician. She is the founder of the DC region's largest physician house call practice and has served as the medical director of 2 hospices and is a well-known elder care expert in the DC metro region. So welcome, Dr. Schiffman and Dr. Mohseni. Thank you for being with us today. And I'll go ahead and turn over the session to you.
Fantastic. Thank you. Thank you, Carissa. I'm going to switch over to our screen share 1 second here. Okay, 1 moment. I want to make sure I put the right screen on here. So of course, hold 1 second. I don't know why we're having a problem here. Let me exit first.
We tested it out.
Yeah, we tested it out, and of course it
worked great then.
I don't know. Hold on. Sorry, I apologize. I'm seeing it, but
there we go.
Yep, that's working.
Yep.
Okay. Do you see?
That's it.
Okay. Yep. Fantastic. Yep. All right. Well, welcome everybody. I'm Mohseni, and this is my colleague Amy Schiffman. We're really excited to talk to you guys today about remote patient monitoring. We're going to go through this kind of quickly so that we can try to leave some time at the end for questions. So let's get started. Before we begin, I do want to say that nothing in this presentation constitutes legal advice. Consult your attorney. The rules and regulations around telemonitoring, telemedicine, remote patient monitoring, are, especially in this COVID-19 era, are changing rapidly. So the agenda for today is the following. We're going to start with what is RPM, what is remote patient monitoring, why are payers promoting remote patient monitoring, why are practices jumping on RPM during this COVID-19 era, what is the reimbursement potential for these sort of programs, what are the key elements of any sort of RPM program. We're going to highlight a few billing notes that everybody should know about. We're going to briefly show a vendor checklist that we suggest you consider. And then finally, we'll tell you how to get started. So remote patient monitoring at its essence is a very simple concept. It's a decision by a clinician that the patient would benefit from some sort of monitoring of a physiological parameter to be done at the patient's home, and more frequently than what we might normally do in the pre-RPM era, where somebody might get their blood pressure checked maybe once every 6 months when they see you in the office. So the idea here is basically that you as a clinician decide, hey, you know, if we actually paid closer attention to either your blood sugar, blood pressure, weight, pulse ox, respiratory rate, any of these things, that we would be able to manage this better, and this would end up resulting in a better clinical outcome for you. That is the general concept of RPM. And Medicare has bought into this and decided that they're going to pay for it, as have many private payers. So the way this generally works is that you order the monitoring device for the patient. And again, this can be a blood pressure cuff, weight scale, glucometer. And that patient takes that device home and they check their physiology typically once a day. And that physiological data comes back to the practice, and then the practice communicates back with the patient. It's relatively unstructured. The rules are relatively open and lax at this time. This is a very, very new program. And most people have found this to be a lot easier to do than other non-face-to-face codes like chronic care management. So why are payers paying for remote patient monitoring? Medicare and other payers are convinced that if you increase the touch points and increase the cadence of communication with patients, that you're going to end up with better care, fewer complications, lower total cost of care, and increased patient satisfaction. And this is really hard to argue against. All of us know that the more you pay attention to something, the more able you are to actually move the needle in getting it better. So right now we're seeing a dramatic increase in interest in remote patient monitoring from many practices and in this COVID-19 era. And we wanted to highlight why that is. So obviously many patients are stuck at home, but they still have a need to be evaluated. Many patients, as you guys know, need their medications to be adjusted. And so how do you continue to evaluate and manage your patients if you're not sure what their blood pressure is running, or how their pulse is running, or if you're not confident necessarily in the glucometer readings that you're getting? So patients need these increasing touch points, but the practices also need the data on which to base this medical decision making. And we are hearing from a lot of practices over the last week or two that they are seeing dramatic drop in patient volumes in their offices because patients, rightly so, are scared to leave the house. And so practices need to find a way to generate income from non-face-to-face encounters. The gut reaction of most practices is to focus 100% on telemedicine. And we believe that although telemedicine is something that all practice should learn about and start doing, RPM is a synergistic program that you should consider doing with your telemedicine program, because you can and probably should be doing both, and they can help each other. I'm going to pause there and see if Amy wants to add anything there.
So yeah, thank you, Alex. So I think the key here is that the COVID-19 era has created a point at which if a practice does not pivot as a good entrepreneur, as most of the people who are in private practice are, unless you can pivot rapidly, it will probably be to the significant detriment of the bottom line of that practice. So I think one of the problems that I have always had as a physician, and when somebody comes to talk to me about something new, I always think, oh, this is potentially just another box to check. I'll use annual wellness visits as an example. I don't think that that's what this is. And I have tried to explain to a lot of the practices, and many of them are probably on this already, that the judicious use of remote patient monitoring or remote physiological monitoring, whatever you want to call it, is actually going to be to the benefit of everybody involved. So that it doesn't feel like you're, oh, great new Medicare billing code. This is like a new workflow that I'm never going to be able to get on top of. This is actually something that will bring both value to the patient, value to the provider, value to the practice, value to the system in a way that is somewhat unique at this point.
Yep, great. So let's talk about what is that reimbursement potential of RPM. And here we're going to just briefly highlight what is the Medicare allowable for the 3 monthly repeating codes. There's a fourth code that is a one-time code. Because of the time restrictions today, we're going to ignore that code for now. The Medicare allowable for the 3 codes is as follows. So 99454 is the code for every 30 days of device and data. So this reimburses typically around $60, $64 per patient every 30 days. 99457 is the first 20 minutes of interaction with the patient or the data. Interaction with the data also counts, and that reimburses about $50 per patient per month. And 99458 is every additional 20 minutes of interaction, which reimburses the same as 99457, about $50 per patient per month, with maximum of 2 units of that per month. So if you add up those numbers together, here you see the totals. We're talking about a reimbursement that's somewhere in the range of about $115 to $217 per patient per month, depending on the number of minutes of interaction. This is the full Medicare allowable. Like any other Part B service, the Medicare would pay 80% and the patient would be responsible for a 20% co-insurance, which if they have a supplemental or Medigap insurance, that supplemental insurance should cover that. So even before COVID-19, everybody recently in the last few months has been talking about RPM. You see it everywhere. AMA, American Heart Association, all these different journals are talking about it. And I want to explain why that is. Why is RPM such an important and different thing right now that every primary care practice, cardiology practice, and similar practices should know about? The key thing is that when RPM first was introduced just over a year ago, it had to be done by the practice under direct supervision. And that sort of program would add too much overhead to most practices. But starting January 1st of this year, of 2020, the rules were updated that remote patient monitoring could be done under general supervision of clinical staff. And this meant that what that generally means is that you can outsource the majority of the work of remote patient monitoring to a contracted vendor. And as these arrows show, the vendor can do most of the work so that you, the clinician, can focus on those activities that actually bring value and where you are operating at the top of your license. And that means clinical decision making. Who needs to be monitored? What sort of monitoring does the patient need? And when there are significant physiological abnormalities, what sort of changes to the care plan need to be made? But in terms of the day-to-day monitoring, each physiological parameter is today a little bit higher than yesterday. How does it compare and trend over time? That sort of work can be outsourced to a third-party vendor to minimize the amount of noise and distraction to the practice. So if you include the cost of a vendor to manage the device and a lot of this monitoring and clinical interaction, we wanted to communicate to you guys, what are we talking about in terms of the potential reimbursement after paying the vendor fee? And as you can see here on the right, after the vendor fees are paid, we're typically talking about a net reimbursement of about $70 to $150 per patient per month. We see many of our practices averaging right around the $80 to $100 per patient per month range currently. So if you do some quick math, if you put 10 patients on and you're getting, let's call it $100 per patient per month, that's $1,000 per patient per month of recurring revenue. So as long as the patient keeps doing this, you keep getting that, which is non-face-to-face. So it did not require an appointment slot in your office. And if you put 100 patients on, you're talking about $10,000 a month. So those sort of numbers for non-face-to-face work, that much of which can be outsourced to a third-party company to assist you, is relatively new and actually unheard of for many, especially primary care practices. Amy, do you want to comment anything on that?
So yeah, I think it's important to understand that these minutes that are being billed are in addition to many of the other non-face-to-face codes, which some of you guys are already using. This includes chronic care management. So if you're doing CCM, this is not duplicative, it is additive. And that the minutes that are applied from the management of the patient as it results from RPM is interestingly billing out at a higher rate per unit time than is CCM. But then you can also be doing CCM in addition to this. So it does not sort of push away any other revenue, non-face-to-face revenue opportunities. It is simply additive.
That's right. Awesome.
That's an important thing to understand.
So what are the key elements of any remote patient monitoring program? We wanted to highlight some of them here, not to scare you, but to make sure you understand, there's quite a few dimensions to this sort of program. But the key message is at the bottom, which is it's the vendor's job to make this all easy. But what are the issues? Because some doctors have the tendency to say, well, I'll do it all. And let me highlight some of these steps. So device management, what sort of devices are you going to use? Who is going to purchase them? Are you going to buy the devices, or is the patient going to pay for the device, or is the vendor going to pay for the device? Who's going to manage shipping and storage of the devices? Who's going to maintain the devices? Then we have patient engagement. How do you choose a good candidate for this sort of program? How do you onboard the patient onto the software and the hardware? How do you keep patients compliant with the program? How do you keep them excited and checking their physiological parameter in months 3, 4, 10, 12? Next is workflow integration. How do you integrate this sort of program into your electronic medical record? What are the requirements for documentation of medical necessity? Clinical interaction. Who's going to be doing the day-to-day monitoring? Who's going to monitor the vital signs that come in at 2 a.m.? Who's going to be the first line of patient engagement when you get an abnormal result, on any sort of day? How are you going to manage billing and coding? How are you going to integrate non-face-to-face encounters into your revenue cycle management process that is probably more geared towards face-to-face encounters? And then lastly, how do you stay compliant? What is your audit trail of the time accrued for each patient? And how do you keep track of the activities that you've performed to support your time-based codes? So this sounds like a lot, but if you choose the right vendor partner, much of this can be done, if not almost all of this can be done by the vendor, so that you can focus on, again, what's critical and keeps you operating at the top of your license, which is clinical decision-making. I want to highlight a few of the billing key points that everybody needs to know. And there are more than these, but these are some of the key ones. So I want to make sure you don't think that this is comprehensive, but a couple key points are that in order to order RPM or to bill for RPM, you must have had at least one face-to-face encounter with the patient in the last 12 months. RPM can be billed, as Amy said, in the same months as CCM, TCM, and DHI. So this is additive to those. The codes are a mix of 30-day and calendar month cycles. So 99454 is a 30-day cycle, and the other two codes, 457 and 458, are calendar month cycles. But a good vendor can actually help clarify this for you so that you never have to think about it. For example, my company will give you a billing spreadsheet each month that tells you exactly which code to apply with which date of service so that your team doesn't have to stress about that. You do need to document medical necessity in the chart. It's not a complex thing, but it's very brief, a few sentences. What is the medical condition you plan to monitor? Briefly, what is its severity and history? What is your rationale for wanting to monitor it? And what are your goals for RPM for this patient? One thing we forgot to document here is you do need to get verbal consent from the patient, and you do need to document in the chart that you obtained verbal consent from the patient for this program. And lastly, RPM is not subject to Medicare's restrictions on telemedicine. As many of you may have heard, CMS actually recently relaxed during this COVID-19 emergency state They relaxed many of Medicare's rules on telemedicine, specifically the geographic restriction that you had to be in a non-metropolitan statistical area, which means you had to be in a rural area. They also relaxed the rule on needing to be in a qualifying originating site, which basically meant you couldn't do it from home. So, but RPM has never been subject to those restrictions. So even when the emergency relaxation goes away, you will continue to be able to do RPM, or you should be able to, unless obviously the rules change in the future. But one more thing, as I said before, there are yet more rules than this, but these are some of the key ones. So here, I'm not going to read through all of this, but I wanted to show you that, you know, Amy and I, we're all about trying to make things easy for our physician friends, partners, and clients. And so this is a checklist that we've created that you can use to take you through all of the different elements you should consider when you are thinking about implementing a remote patient monitoring program and you are evaluating vendor partners for yourself. So, you know, some of the key ones here that I want you to think about are the connectivity medium. How are the devices supposed to digitally send their data back to your vendor and your practice? Many RPM companies rely on the patient to be able to manage Wi-Fi and Bluetooth and tablets. Amy and I's assertion is that that is too complicated for most patients, and we believe the best solution are those vendors who focus on a cellular solution. And by cellular, I don't mean the patient's cellular phone. There are devices out there, and many of you probably don't know this, that have a cellular chip built into them, meaning a blood pressure cuff with a cellular chip on its own cell plan built into the device. And this is actually the type of device that we use, because we have found that if you don't make it simple for the patient, the program is simply not going to work. So what this means in our specific situation is that each device is registered with that patient before it's even shipped to the patient. And so when they press the stop button and start checking their blood pressure, that data is sent automatically back to the home station, meaning your practice and the vendor's platform, without needing the patient to have a smartphone, without needing the patient to have an app, Bluetooth, Wi-Fi, anything. They don't need, as long as they can get a cell reception, meaning they're not, you know, deep in the woods.
Or a Faraday cage.
Or a Faraday cage, then we will get that data. A couple of the other ones I want you to think about are on the patient engagement side. One that's really important is how do you keep patients excited and engaged in subsequent months? You know, so some good vendors out there have really great engagement recovery programs, and they're calling the patients and talking with them, and sometimes offer even games and prizes. And so the patients get really, really excited about this. Some vendors will also even pay for the consumables of a device, meaning pay for the glucometer test strips in order to keep patients excited and compliant with the program. A couple other things to think about are the clinical support. Is the RPM vendor that you're looking at, are they just giving you the devices and expecting you to do all the clinical monitoring? Or are they going to be the first line of clinical interaction? In the workflow integration, how does all of this integrate with your electronic medical record and in your workflow so that you don't have a major disturbance to your workflow, and this can be as smooth and easy as ordering any sort of other service? How is the billing and coding going to be done? How is that going to integrate into your current RCM process? And what is the audit trail? So that if Medicare ever comes and says, show me the 20 minutes on that patient, what are you going to show them? The way our system works, and I think is a standard that I would measure everybody else against, is that all of our interactions with patients are done through a secure voice over IP system, where the conversation with patients is actually recorded and transcribed, so and automatically timestamped. So if Medicare were ever to come back and say, show me the 20 minutes on this patient, not only can you show the timestamps, but you can actually say, here, listen to the actual conversation. So this was a very brief overview. There's more to be learned, but we wanted to make sure we leave some time for questions. Amy and I have created a remote patient monitoring workbook and a billing guide. If you're interested in learning more, we suggest that reach out to us. Don't hesitate to reach out. You can text us. You can see our email addresses here. Feel free to reach out and ask us any questions you have.
I'm going to add a few things in there, Alex. Thanks for going through that whole amazing slide. There's a few things that I wanted to point out that we've come across as we've been able to talk to so many different practices. And one of them is that this is what we would call a last mile problem, which is there is certainly the propensity to analysis paralysis for this, which is you could sit and talk to the 300 different RPM vendors that are out there and start understanding, they come in different sizes and shapes. The FDA has approved lots of different devices for this. They've even approved some software packages that can then, using Bluetooth, then connect back to a device, which then connects back to the provider. And it all actually seems so incredibly overwhelming that you cannot actually imagine implementing even slowly such a program unless you kind of stuck with a single vendor, single set of products, a single mindset, if you will. And for that reason, a lot of people, because of the analysis paralysis, don't even think beyond an overly judicious sort of approach to which patients you would choose to put on this. So the approach that I've taken, as I've thought about this, for my own practice and for other people's practices, is that you can almost be too judicious. Differently than chronic care management, where you're required to have chronic medical problems, you can actually implement RPM just by your own clinical judgment. It would be very helpful to have a blood pressure cuff in this patient's house, and this is why, and I need to follow them for this reason. And certainly it makes sense to some degree to look back at your ICD-10 coding and your Medicare coding and say, wow, 60% of my patients who are Medicare patients have hypertension. Given that I'm not going to be seeing them in the office, I'm not going to be checking their blood pressure, it may be reasonable to put an RPM device in that home. It can be incredibly complex to sort of think about taking a gigantic new potential workflow and throwing it in the midst of the chaos of starting a telemed program. And so I think it's important that when you choose a vendor, you think of them as a last mile partner, somebody who is going to take you through all those different steps that we just went through, which is from choice to how the patient gets the device, to how to make sure the device is working in the patient's house, to who is the patient going to call when something happens to the device. Are they going to flood your front office with all of these questions? You want to make sure that the vendor that you choose is much more than just a device distribution center. They're going to need to provide a certain level of services. And that speaks a little bit to what Dr. Mohseni had alluded to before, which is a lot of people will say, oh, well, I'm just going to do this all myself. I'm going to go get a bunch of devices and I'm going to put these in these patients' homes and I'm going to manage this portion and this portion I'm going to manage. Also, I can save $12 to $15 to $17 per patient per month. It has been our observation that in order to save yourself the aggravation, it is probably better to look to RPM companies that provide full service, that provide third-party integration, that will take the first call if the patient's blood pressure goes outside of the parameters that you want, so that your front office, which may in fact be a skeleton right now, is not going to be the one that's going to be handling that. So I think that sort of summarizes sort of my summary, summarizes all that stuff that Alex had talked about.
Yeah, we do have a few questions. So thank you, Amy.
Great.
That was awesome. So one question is from Susan. Is RPM reimbursement available to all physicians or only certain specialties? Example, primary care doctor. There is no restriction on the specialty. So we are seeing, obviously, many primary care doctors doing this. We're seeing many cardiologists doing this, endocrinology, pulmonary, absolutely. So there is no restriction from Medicare in terms of the specialty. It does need to be ordered. The RPM service needs to be ordered by a qualifying healthcare professional, which means a physician or nurse practitioner or physician assistant.
Alex, I'm going to throw a question your way. I think I know the answer, but if a primary care doctor already has RPM in the house, can the pulmonologist add an additional device and then bill on top of that? Or is it a first come, first serve?
I believe, my understanding is that it's first come, first serve. So there's a little bit of a land grab going on right now. So it would behoove you to be early in the land grab. This is still a relatively young program, so most primary care doctors are not doing this yet, but there has been a huge surge in the last 7 to 10 days, I'd say. The next question somebody asked, is this only Medicare patients? No, this is not only Medicare. In some states, Medicaid is also reimbursing, and actually in some states, Medicaid is reimbursing even more than Medicare, for example, in the state of Texas. In Maryland, where we are, the rules for RPM are tricky and limited to two-month aliquots of RPM, and it has to be like a post-hospitalization type situation. I generally find it just not worth your time or money to do Medicaid RPM in the state of Maryland. And then many private payers are reimbursing, but you will need to check individually with each private payer. Another question is pulse oximetry one of the device options? Absolutely, 100%.
Okay, so the next question is, RPM can be done per vital sign, or weight, BP, heart rate, glucose can be monitored separately and billed separately? So the answer is no. You sort of, if you've 10 devices in the home, you are billing only at a maximum of those 60 potential minutes with the one code. You don't get additive. The more stuff you've got in the house, you don't get more. It's just sort of those very few. Alex, you want to add anything on top of that?
Yeah, and there's this nuance. Dr. Rizikov is asking, glucose can be monitored separately and billed separately. So this is actually a great question. So prior to this general RPM, there have been some reimbursement codes for monitoring of specific physiological parameters like glucose. And so I don't want to get into the nuance here yet on the platform, but that is a nuance that needs to be clarified, meaning, and we can help kind of work you through that. But there's a little bit of a difference between RPM monitoring of glucose and the previous code for glucose monitoring. And we can talk about that offline if you're interested. Reach out to us. And there's a similar question. If PCP does BP monitoring and endocrine does continuous glucose monitoring insulin pump, is that billed only for one provider? So I think the type of glucose monitoring that has been done previously is my understanding, a different code from the RPM code. So it is possible for endocrine to continue doing continuous glucose monitoring, which is a non-remote patient monitoring code, meaning not one of these three that we talked about, and the PCP doing blood pressure monitoring separately. Great question. Are any of the private payers reimbursing RPM now? Some are, and you do need to reach out to your local payers. We believe CareFirst is, but it also depends on which plan it may depend on which plan.
If you are PCMH, you are getting, we know this, that you are getting reimbursed at 100% for your telemed office-based codes, and we have been told. So this is, again, please consult with your with the payer, but we have been told that RPM will be the same. But again, I think one of the little pieces of advice that Alex and I have been throwing out to folks is the best bet is to go ahead and start it on a couple of your patients, send out the bills, see if you get paid, and go from there. Now, if you are referring to the CareFirst as a primary, that's what we are referring to. If you are referring to CareFirst as the secondary payer where the primary is Medicare, my understanding is that they are going to pay that additional 20%. So the patient will not be left with any payment.
Another great question. Please explain the 20-minute portion. Is this the times the physician is on the phone with the patient? No. So most people who are doing RPM are using a vendor. And many of the vendors have a clinical team, and the clinical team is doing the kind of daily or every other day interaction with the patient, review it. So the 20 minutes of time can be accrued by activities including calling the patient, but in addition to that, just reviewing the data itself accrues to that time, as does comparing the data to prior data, as does reviewing the patient's care plan and adjusting the care plan. So much of the 20 plus minutes can be done by non-physicians. They can be done by lower level clinical staff, including non-APP, non-PA, level below that. And then the physician portion, if they do need to jump on the call with the patient, that can accrue towards that as well.
I want to add a little bit to that. So if you think of RPM as part of the family of non-face-to-face codes, if a physician engages in chronic care management or any sort of telephonic management of the patient, either through themselves or through the third-party vendor or whatever, if the physician is directly talking to the patient and accruing minutes, they can ascribe those minutes either to RPM if it's as a result of an RPM, something that came up as a result of the RPM, or they can then use that same set of minutes and put them to CCM. You can't double ascribe, but you can choose where you want to put those minutes. If you are using a vendor, you may find that vendor has a portal where you can actually call the patient through the portal, document through the portal, but you have to be aware that if you do that, a lot of times the vendor will be taking a small amount of money, even if the 20 minutes was done by you. If you had signed up for the vendor assist on each of your monitoring, those minutes, even though you're doing them, may still be subject to some payments because you are doing it through the portal. If you choose to do it yourself, then you can bill it however you want, as CCM or 99358 or other non-face-to-face codes. I'm sure I've very much confused everybody. I'm happy to answer any offline.
All right, so this is a reminder to hit *6 if you've dialed in via the telephone and would like to ask a question. All right, so I think that we'll go ahead and we'll close it. If you do have last-minute questions, feel free to enter them via the chat box or interrupt me. So I just want to say thank you to everyone for joining us today. We will make this webinar available online via our YouTube channel. So we'll send out the link after the educational session. Please don't forget to subscribe if you are interested in more educational content like this. And we've already got webinars up on the channel regarding employment law and also about how to launch a telemedicine program. So if either of those topics interest you, then please visit us there. We also want to make you aware that MedChi, the Maryland State Medical Society, they have launched a daily call for updates on COVID-19 with the Maryland Department of Health. So if you are interested in dialing into that, it's happening every day at 5 p.m. And in your post-event email, we'll send you more information about how you can participate in that call if it would be helpful to you or your practice. And then finally, we did launch a new Facebook group for physicians this last week so that local physicians still had the opportunity to talk with other doctors who are local to our area, who we know are licensed in Maryland, in a private space. So we'll send the link out to you. So if you'd like to participate in that, please do go ahead and put the request in to join. We're approving people as quickly as we can. And finally, we're also going to have a digital collegiality dinner or a digital collegiality chat on April 15th. So please pencil that into your calendar. We want to keep bringing physicians together, even if it's not possible to all be together in person. That doesn't mean we can't network and socialize and share experiences. So thank you everyone who joined us, and thank you especially to Dr. Schiffman and Dr. Mohseni for helping us put on this session. We couldn't have done it without them, and their expertise has been really invaluable. We will include their individual contact information in the post-event email. So if you're interested in getting in touch with either of them, then please don't hesitate to do so.
Thank you very much.